Looking for a doctor near you? Get instant appointment.
Where is the meeting?
Hi, Dr. Rajiv, how are you? Hello?
No, I can't see it.
Hi, Dr. Rajiv, how are you?
Please wait. Wait.
Hello?
Wait, no, बेटा.
Hello?
Hello, Dr. Nadeem.
Yes, how are you? Can you hear me?
Yeah, so by mistake I logged in through Microsoft Edge. So is it okay? Should I shift to Chrome?
No problem. Microsoft Edge is equally okay, no problem.
Okay, fine.
So long as you are able to share your PowerPoint, that's perfectly fine.
Okay, fine. So
whichever browser you want to use, there's no problem.
No, because I use Chrome only, but by mistake.
So you can shift to Chrome, no problem. We'll wait for a minute, no problem.
Yes. I will just shift.
Just log out and log in.
Yeah, Dr. Nadeem, I'm back.
Yes, you're fine. Right,
yes.
Should we start? You ready?
Yes.
Fine then. Good evening, everybody. Welcome to this evening episode of Pursue. And this is Pursue 12I, and this is Respiratory Pathology. We are streaming live from Tata Memorial Hospital, Mumbai via Kolkata. Today's topic is very important, very relevant, and a very hot topic of the day, which is biomarkers in lung lesions. And to talk on that, we have Dr. Rajiv Kumar Kaushal, who's a professor in the Department of Pathology, Tata Memorial Hospital, Mumbai. Dr. Rajiv Kumar Kaushal, he has received his medical degree from Grant Medical College, Mumbai. Then he did his residency training in pathology at TMH, Mumbai. And then he joined PGI, Chandigarh, where he spent 3 years doing his senior residency. He rejoined Tata Memorial Hospital as an assistant professor, and right now he is the professor in the Department of Pathology. His area of interest is thoracic, gastrointestinal, oncopathology, molecular pathology, and digital pathology. Mayo Clinics have awarded him the Geraldine C. Ziller's Fellowship to participate in Mayo Clinic visiting clinical program at Arizona, USA for training in pulmonary pathology. He is also a recipient of the Terry Fox Research Grant. Along with his routine work, he is responsible for the administrative activity in establishing digital pathology network in all various centers of Tata Medical Centers. He's got multiple national and international publications. Before I ask him to start, let me request you to keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Rajiv sir, please share your screen and let us start.
Thank you, Dr. Nadeem, for the kind introduction. And so let me put my slide.
Just present now. Yeah, that's right.
So, can you see my screen?
We can see your screen. Everything is fine. Please start.
Okay. So, moving on to the topic of today, that is the biomarkers in lung cancer. And just to continue with this slide which I showed in my last lecture on approach to small biopsy, as we are now well aware when dealing with them, especially with the neoplastic lesions in the lung, we have to not only restrict ourselves to the making a diagnosis, but the tissue travels a long journey right from the immunohistochemistry followed by molecular testing. And there is a long unexplored journey which this tissue underwent, and why it is become relevant now, because lot of genetic alterations have been now described in lung cancers, and of which EGFR, KRAS, ALK and ROS, they are the common mutations. And now it's almost a decade when initially EGFR came as a first targeted agent, especially in the lung cancer. You can see from these slides many new alterations has been described, and that's why the lung cancer is now emerged as a solid as a role model for in the precision medicines. And due to these developments, now in many other cancers, especially in the advanced stage cancers, biomarker testing is being done. So the biomarking testing, that's why it is, especially in the lung, is no longer remain as a research tool. It is done in almost all the patients, and even in the Indian clinicians, they also use these services very regularly. So we can't go when we are dealing with the lung cancer. We have to understand these genetic alteration as well as the potential biomarkers about it. So as I mentioned earlier, the testing algorithm for these tiny biopsies, it first go to the histological subtype, and then what are the types of biomarker tests. You can broadly categorize them into the two subtypes, like one are you can say as like a test tube based test, and other is a morphology based test. In the morphology based test, I mean the ISC and FISH based test, because now there are certain biomarkers for which corresponding immunohistochemistry is available, and they are approved by US FDA for clinical use, and the ALK is the best example of that. And the tube-based test means in which the ribbon of the tissue is taken and put into in a tube, which further undergo various steps of DNA and RNA extractions, and these include EGFR, KRAS, or NGS based test. So the Association of Molecular Pathologists and CAP and International Association of Study of Lung Cancer has given the guidelines, specific guidelines about the molecular testing, and I recommend every one of you should go. These are very nice article, one published in 2013, and the revised guidelines came in 2018. So I'll just highlight what are the main changes between these two guidelines. So the first guidelines which came in 2013, they were restricted only to the EGFR ALK. But now the scope of the testing has been extended, and even ROS is also included as one of the initial targets and which need to be tested in all the cases. And if you are doing the multi-gen gene testing or extended panel, then the other alteration like MET, RET, BRAF, HER2, they can be included in the molecular profiling of that particular case. But testing for EGFR, ALK and ROS, this is for these three markers is more or less mandatory. The next thing is which tumors to be tested. As most of these alterations are described in adenocarcinoma, so it is recommended all advanced stage lung cancers should undergo molecular testing. But even if there might be some cases which are either labeled as a non-small cell carcinoma, NOS, or even squamous carcinoma, but in the clinicians, if they feel that the possibility of finding a genetic alteration is high, so those cases can also be tested, but that depend on the treating team or multidisciplinary team decision. Moving on, the third recommendation is about EGFR. As I already mentioned, that this is one of the commonest alterations and found commonest alterations. So now for this, in the new recommendation, as the technology is advancing, earlier the cutoff for the was 50%. The platform should be 50% sensitive, but this has brought down to the 20%. Means even if you have a less amount of the tumor, it can still be you can still be progressed to the testing for EGFR. For ALK, earlier only the fish was considered as a gold standard, but now ISC is also accepted, and it has become as a FDA approved companion biomarker for identification of ALK cases. But for ROS, IC can be used as screening, but if any case can be positive, it needs to be again verified by using an alternate genetic test. And NGS panels, as we know that many people now talk about doing NGS, and so if they should be preferred over the single gene panels for extended testing. And but we have to keep in mind about the cost effectiveness and about this technology. Although everyone wants the large coverage, but it is the testing by NGS is full of challenges, and I'll discuss a little bit about that in the subsequent slides. Next is about the tissue type, which tissue type should be tested. So in tissue type, now it is recommended not only the biopsies specimen, but also the cytology or other samples which can give you a significant good result can be used. And now the stress was also given on the utility of the liquid biopsy, especially liquid biopsy cell-free DNA, because if you get a positive result on that can be reliably considered for the targeted therapy. So these are the few of the recommendation, and T790M is another EGFR resistant mutation. So there should be attempt to find out these mutation, and your EGFR panel should have coverage for that. So these are just summary of these molecular testing guidelines. So moving on, as I said earlier, which material to be used. So any sample which have a good amount of viable material that can be used. And so if any patient has more than one sample, so you should try to evaluate both, and which is more viable, showing less of necrosis, though that sample can be used. If you are using cytology as your sample for the molecular testing, then you need to standardize and validate your protocol according to the cytology, and because you can't reciprocate the same recommendations or the same protocol which is used for paraffin tissue on cytology specimens. So hence the planning should be very meticulous whenever you are dealing with these cases. So as I mentioned earlier, The aim should be to have a good enough material, and which is many times challenging, and we have to keep in mind that the tumor content even can be compromised by many factors, especially in the lung. There can be necrosis, hemorrhage, mucin, and fibrosis. So in by and large, you will most of the cases you will see that the tissue cores will contain 40 to 50% of the tumor and not more than that. Next, moving on, just can you give me 1 minute? So, how should this specimen be tested, or which method to be used? As now we know that we have multiple options available, ranging from PCR, fish-based tests, ISC, and NGS. So, what is the appropriate test for the specific target? I'll go into detail of into these as per the which is the potential target. So as we know that EGFR mutations, that is the commonest mutation which is found in the Indian population, and we have to keep in mind that the EGFR is not just positive or negative. There are some mutations which are drug sensitive mutations. At the same time, there are alterations which are drug resistant. So the platform should be able to pick up and tell you about these mutations very precisely. As we can see, the exon 20 mutations, and especially T790M, they are the drug resistant mutations. So we have to keep in mind which type of mutations is identified whenever you see a report of EGFR positive case. And our next thing is what is the preferred method? So for EGFR testing, now many platforms are available, and which have a very good and high sensitivity, and they don't even allow you to test for the EGFR in tissue, but as well as it can be tested in the plasma samples. So you can choose your platform according to it, how much coverage it is giving, how sensitive the platform is, and whether it can provide you the option to test plasma, because many requests for EGFR comes now on the liquid biopsy or even any type of fluid for that sake. In that digital droplet PCR, that is one of the very sensitive methods. So even if you don't have NGS or other high-end machines, so the digital droplet is a very sensitive method, and it is recommended especially for the liquid biopsies. Moving on, what is the prevalence and of EGFR in India? It ranges from 21 to 40%, and there are some data which, especially from the South India, which shows there is a still higher prevalence as compared to in the studies from the North India. And in our the study from our center, it shows the prevalence in the range of 25 to 30%. Can we do the EGFR testing in squamous carcinoma? Is it worthwhile or not? In our center, we do it, but and there are no standard guidelines for that. But we have found that EGFR mutations were found positive in around 4 to 5% of the squamous carcinoma as well. So it's worthwhile testing, and especially when there is no alternative clinical option, even in the case of squamous carcinoma. Next question is, what are the other methods to check for? Are there any other methods to test for EGFR? Can we use ISC or FISH? So it is recommended not to use these two methods for EGFR screening, because our intention is to look for mutations, and these mutations, as I mentioned earlier, they should be. We have to look for not only the sensitive mutation but also the resistant mutations. So there are some ISCs which are available, like I showed. There are exon 19 and 21 specific mutation specific ISCs, These, if you want to use them, only these can be used, but they will not give you a wide coverage which a PCR based assay can give you. And further, the fish testing is not recommended, because that will give you the idea about the amplification and not about the type of mutations. So this was in short about EGFR. Moving on, the other two common alteration, that is ALK and ROS. So for testing for ALK and ROS also can be done by various methods, and for ALK, fish and ICs are the commonly used methods. And this is just a pictorial representation of a ALK positive case using fish. You can see now there are nicely split signals. Split signals means as compared to the case which shows red and green signals which are very close to each other, and many places cells, you can see it appears as a yellow signal. In contrast, positive cells, these signals are widely apart. So this is a case of rearranged tumor. And if while counting, if these types of cells they are more than 15%, you can clearly call this case as a positive. There is another pattern of expression of positive signals, in which there can be a loss of green signal. Means you will see only isolated red signal. That is another pattern. So you have to add up both split signals and loss of green, and finally, if your count is more than 15%, the case is positive. As I said, now the ILC is also FDA approved one biomarker for detection of the ALK rearrangement, and D5F3 Ventana clone is recommended to test for that. And so this is like an assay. You have to do this testing using the complete recommendation as per the vendor, that is this is by Roche, and it has to be tested only on the Ventana platforms. So if you are using it as a manually, then it doesn't remain a companion diagnostic assay. It is like a local lab test, and that should not be done. And the expression of it is usually you get a very strong and brown granular positivity, as shown in these two cases. So the good advantage of ISC as compared to the fish is that it is easy to interpret, and even if there are less number of the cells, you can still use it. So that's the question which many people ask: can we use ALK-IC without Ventana? It is not recommended. And just to show our experience of ALK testing in TMH, and the overall positivity we get is around 11%. So initially, so our cases might be little enriched by first we used to do EGFR testing, and only negative cases we used to take. But with the advent of ISC, now all the cases upfront go for ALK testing. So overall prevalence is around 11 to 12%, and there is a similar data is coming from other centers in India. So is it impact of ISC which is helping us to pick up more number of ALK positive cases? We need to look into it. Moving to ROS, as I said earlier, the new recommendations or new guidelines, they said testing for ROS is as one of the major change which came in these guidelines, and ISC can be used as a screening. But many labs still they don't test for ROS, and if they are using, they use ISC, but the ISC has to be reconfirmed by fish. This just to show a few of the examples. So as compared to the ALK, the ROS ISC expression is usually heterogeneous and can show some variable patterns like example showing a globular positivity, cytoplasmic, membranous. So expression is not as uniform as we see with the ALK positivity, and so it is now recommended to when we if you are using ROS testing by ISC, so it is recommended to report both intensity as well as the amount of expression, and finally give a H score. So if your H score is more than 100, then the likelihood of the case being ROS rearranged is very high. And now that about just to show you the data about the concordance between ISC and fish for ROS and ALK. So ALK has shown a good concordance with high sensitivity as well as specificity, whereas in contrast the ROS ISC, although it is sensitive, but the specificity is low, as you can see with these figures. So whenever any case which come positive by ROS ISC, it need to be reconfirmed by alternate method before starting the therapy, as summarized illustrated in this cartoon. So this is the summary of the available test which is available for ROS testing. And now the next question is, can we use PCR based test for detection of ALK and ROS? The answer to that is no. In the clinical use, the PCR or RT-PCR should not be used for this. And the answer why it is important, because both ALK and ROS has many fusion partners, and it is not possible to cover all. And if you have unknown fusions, it can be again missed. So that is a drawback of using PCR based test for detection of ALK and ROS in the lung cancer. So moving on to the high throughput or multiplex plot platforms like NGS. So these platforms now with the advanced with more development, and these are more preferred from the clinical side, because at one go they give the answer. And especially if you are looking for the genetic alteration beyond EGFR, ALK and ROS, they are the method of choice. And so because it gives a good solution to the genomic biomarker shopping list, you can say, but we have to keep in mind they are costly. In addition, they require more expertise, not only in the wet lab but also in the analysis of these results and there should be a good bioinformatic pipelines. And another drawback is that sometimes the NGS reports it takes relatively more time as compared to the other conventional methods, and sometimes it gives lot of data and might confuse the clinicians, because especially if there are no specific targeted drug is available for that particular gene. So now NGS is becoming more and more, it is getting integrated into the diagnostic algorithms, especially in the lung cancers, and there are various panels are now available, like limited gene panel. In TMH we routinely do 62 gene panel on the Illumina platform, and there is Oncomine DX panel on Iron Torrent, which is also FDA approved especially for the lung cancer, which cover most of the available targets. But with the utility of NGS, there are many questions arise, like is it feasible to do it in all the patients? And we know that as a pathologist we are not bioinformaticians, and interpretation of these cases, this test can be challenging. And further, we have to keep in mind it's not only the RNA based or DNA based assays. So if you are using a good panel, that should give a coverage, but all RNA based assays, they are difficult to handle, and the as compared to the DNA based assays. And many labs are now offering a very small gene panels, sometimes I see the reports of even 5 gene panels. So are these gene panels reliable or not? Those should be properly validated before the with the standard platforms. Then only we can really rely on these tests, especially with the small gene panel. And as I said, it might take some time for the NGS reports to come. So many times, even in our hospital, what clinicians do, they test for EGFR, ALK by RT-PCR, and ALK and ROS by IC. So they get the report early and can decide on the therapy immediately. So moving on, there's another challenge which both the patient and the clinician faces, because many of these patients which are on targeted therapy, they develop either recurrences or progressive disease, and how to handle them, and what is the role of, is there any role of rebiopsy or liquid biopsy in those cases, because now the new generation TKIs are also available. So as a pathologist, we can play two major roles in this scenario. One, by telling the clinicians the possible reason for the progression or the recurrence, and how we can do that. All especially so in all those your biopsy cases which are earlier reported as adenocarcinoma, you have, and some initial molecular testing was done which showed the especially EGFR mutation. You have to look for the presence of small cell transformation, and you should document it in your report, especially in the rebiopsy samples, both even if it is present or absent, so that clinicians are aware that you have paid attention especially towards the small cell transformation. In addition, we have to look for the possible reason for the resistance, and T790M EGFR mutation is one of the common reason for the mutation. Other known reason for acquired resistance are illustrated here, in which MET amplification is one of the common reason. And in addition, now for the patient who are on ALK inhibitors, also there are certain mutations which are likely to show the resistance, and in these particular cases alternative ALK inhibitors should be attempted. Now as I mentioned that if in case of recurrences, there are two options clinician has. One is to either do the rebiopsy of the lesion, or second option is to check for any alteration on the liquid biopsy, because it is relatively non-invasive, and so can we rely on the liquid biopsy reports. So we have to keep in mind 2-3 things. One is important thing is that pDNA should not be used for the diagnosis. You can use it especially for the EGFR T790M mutation, and if your results come positive, you can safely rely on that. But if the results are negative, then you might again need to go back to the tissue to look for the alternate possible rearrangement. So this was based on the markers which are available for the targeted therapy, and now the immunotherapy is also coming as a major role in the lung cancer, and these are the few of the markers which are available, biomarker which are available for the immunotherapy, and in which PD-L1 tumor mutation burden and MSI, they are the commonly talked about and are available in the clinical practice. Out of these three, MSI still has not been approved as a potential biomarker in the lung. but in the GI tumors, it is very frequently being used. GI tumor, endometrial carcinomas, it can be reliably used. So, one of the most important biomarker, that is the PDL1, which is being used in clinical practice, and now there are many tumor subsites for which the immunotherapy has got approvals, and but we have to keep in mind at various sites the cutoffs and the reporting criteria are different. So is PDL1 is a really potential biomarker? Yes, there is no clear-cut answer, but if the expression for PDL1 is higher, like if it is more than 50%, you can safely, the clinician can safely give the course of immunotherapy, because we very well know that these therapies are very, very expensive, and if the expression is low, then at the beginning only the clinician can say, I am trying these expensive therapies, but you should be cautious whether the tumor will respond or not. There are certain differences between the PDL1 as compared to other biomarkers. The first and foremost, it can be used for the both squamous and non-squamous histology, and usually most of the other biomarkers, they give a black and white answer, but here the expression can be variable, and even if you see, and there's a lot of heterogeneity also in the PDL1 expression. So if the expression is more than 50% only, then only in those cases you can use it as a first line, but as a second line the role is still not very clear. And the expression, third is the expression is not only restricted to the tumor, but you can see the expression even in the immune cells. But till date in lung cancers, we have to evaluate only the tumor cells and not the immune cells, and the expression of PDL1 can also change during the course of the therapy, and also based on the other adjuvant therapies like chemotherapy or radiation. So that's why the PDL1 is not a very reliable marker, but till date there is no other alternate markers, so we have to go with PDL1 only, keeping in mind about the heterogeneous expression or the variability in of expression of PDL1 in mind. So then and another challenge for the PDL1, because it is the one marker which has given a very a great trouble to the pathologist, because the FDA approvals were not only for the ISCs, but it is for the complete assays. Means you have to run like there are FDA approved assays like 22C3 DACO antibody, which need to be done and done only on the DACO platform. Then only it becomes a companion assay. So there are challenges using the different PDL1 antibodies on different platforms and using them on a different disease. So this is like a 3D fit for the purpose strategy. Means there should be a corresponding drug pertaining to a specific disease, and for that a specific test should be there, and which is practically very sometimes become impossible to have a different clones of PDL1 which are available now. So can we use these companion diagnostic or lab test? Are they interchangeable? The answer is in ideal situation it is not interchangeable, but if your clinicians they are okay with that, you can go ahead. Even so this 22C3 for Tambro is the FDA approved diagnostic assay. And just to show why it is, if someone asks me, can I use this kit on the some alternate platform, there are some studies in the clinical research where it was attempted. You can do it, but it will change it to the lab test, and you have to report it accordingly. So just to show So this is a 22C3 antibody, which is FDA approved, and if in case you use some other clone for the same purpose, it becomes a lab drug assay. But at the same time, we have to keep in mind, like for atezolizumab, that is a drug is used, and pembrolizumab also another FDA approved drug. So for this particular assay, PDL1 SP142 is the clone which is approved. So we can't use these assays interchangeably, and so we have to be cautious which assay you are using, which platform you have, and then report accordingly. Out of the various assays which are available in the market, SP263 Ventana clone and the other DACO antibodies, they have shown the comparable results, and as compared to SP142. So now it is recommended that these two clones, like from the 22C3 from the DACO and SP263, they can be reliably used in lung cancer. And next step is, if you are using or testing for PDL1, how to interpret that, because interpretation of the PDL1 is another very challenging thing, and pathologists should be aware how to go about it. So if you are reporting PDL1, you have to keep in mind about these three basic principles. First thing is always check for your controls, whether they are working properly or not, and is your sample adequate. Sample adequate means there should be minimum of 100 tumor cells in the biopsy specimens. The next step is determine the number of positive tumor cells and the immune cells if you are using the CPS scoring, and finally calculate the score based on that. So as I said, if you evaluate the appropriate positive and negative controls, and is the sample sufficient, only if you meet these two criteria, you need to go ahead. Otherwise, you have to repeat the staining. And as a control, tonsil is the very good example, good tissue which you can use for standardization and even for the routine controls. So in tonsil, the crypt epithelium usually shows the strong expression as compared to the surface epithelium, which is usually negative, and the dendritic cells, they show weak staining. So using the one stain, you can cover all spectrum of the staining which is possible in the routine practice. So as I said earlier, the minimum of 100 viable cells should be present before interpreting the PDL1 expression. And after, so this is the formula. If you're using the TPS, so you have to count the PDL1 staining tumor cells and divide by the total number of the viable cells into 100. So if you are using a Ventan and DACO antibody, then you have to report it as a TPS. But if you are using a Ventan or other platform, you can only report as a percentage of the tumor cells without mentioning the TPS. But both of them are one and the same thing. And if you have to report about the CPS, although it is not till date not used in lung, but many other sites now we have to report CPS, in which immune cells, especially including lymphocytes and macrophages, need to be counted. And this is a summary of the difference between both. But till date for the lung, we have to restrict ourselves to TPS. But for just to give you a glimpse of what are the recommended cutoffs for CPS, because for the different sites. So for cervical cancer and adenocarcinoma of the G junction of the stomach, it is cutoff is 1, and for urothelial carcinoma and esophageal squamous carcinoma, cutoff is 10, and head and neck squamous carcinoma, it is now considered to be 20%. So PDL1 testing, as I mentioned earlier, it is very full of challenges, and these are the possible solutions. So challenges can be due to the assay specific challenges, which can be resolved by cross industry collaboration like blueprint studies. They can be biopsy specific challenges, which due to the heterogeneity, and there might be the patient specific challenges. So is the question at the end arises: is PDL1 testing is a reliable marker, and is it mandatory? So if you ask or take a survey of many clinicians, so they will say it all depend at you are going to initiate the immunotherapy at as a first line or in the subsequent line. But in our practice in TMH now, as a baseline PDL1 testing is done in most of the cases. And I've already told you what the various challenges which you can encounter while dealing with the PDL1, and what are the other any alternate biomarkers for immunotherapy, the tumor mutation burden and MSI. They are the alternative method, but not practical in the day-to-day practice due to as tumor mutation burden, you need to have a gene panel which give a coverage for then only the results for the TMB can properly addressed. So to summarize, there are molecular testing in lung cancer. It is full of challenges which ranges from the technical challenges to logistic and tumor biology, and this hence in the today's era we have to match as a pathologist, we have to match with the clinician's requirement, because these all these genetic alterations has a major therapeutic impact, and judicious use of ISCs along with the molecular testing is now standard of practice. And although there are no major changes in the 2013 guidelines, but in the new recommendations now testing for ROS and additional gene is now and NGS platforms are now becoming the routine. So as you can see, this is my last slide. So the diagnostic armamentarium, especially for the lung cancer, has evolved extensively, right from the histological classification, then ISC, molecular testing, and now in future maybe digital pathology and AI algorithm may play a major role in predicting the course of this disease. With this, I end my talk, and thank you for the patience.
Wonderful, wonderful. Excellent talk, my God. This is so good. And you have ended on a very, very, very important note. Absolutely, digital pathology and the algorithm and the Indian perspective of that, and especially discussing the TMH series and their experience is so very good. Hardly we'll be able to ever get to know all this. Thank you so much, Dr. Rajiv. Wonderfully done. Excellent presentation, and the content is so good. I think everybody will go back and listen to it again and again to understand exactly the biomarker activities in lung tumors. Thank you so much. I think there are no questions as I can see. Yes, there aren't any on the... So I think we will close here. Thank you so much, Dr. Rajiv, for taking out time and from your such a busy schedule and taking out 3 lectures back to back. Especially knowing that on the end of this month you have such a big conference which is absolutely on your shoulder. Still, thank you for your commitment. Thank you so much. Take care. God bless you.
It's all my pleasure, and
the pleasure is all ours.
Yes, thanks.
It's an honor to have you here on this thing. Thank you so much. Take care. Bye bye. Good night.
Thank you.
Thank you.